So we hear the term precision medicine used in cancer care now more than ever. With greater availability of clinical trials and state-of-the-art testing tools, how do you see precision medicine evolving in the treatment of MPNs?
Excellent question. So I think the term precision medicine is one of those terms that gets thrown around and used quite a bit, but actually the way you're using it is this sort of correct and most important way, which is personalized molecular-based medicine for our patients with pre-leukemia states, leukemia states, other blood cancers. For the MPNs, this is very important. I would start the discussion by reminding all of our viewers that our field was one of the first to use precision medicine. Why? 90% of people have a driver mutation. So let's review what those are. The big three: JAK2, CALR, MPL. That probably makes up about 85% of our patients. But we didn't really base treatments based on that, as many of our viewers know. So the JAK inhibitors, ruxolitinib, fedratinib, pacritinib, momelotinib, et cetera, importantly, are not JAK2 mutant inhibitors. So actually they work on all the patients regardless of this mutation status. But a second generation of personalized precision medicine is coming. David, that is where we and others are starting to check additional molecular mutations: ASXL1, IDH1 and 2, EZH2, SRSF2. The alphabet soup continues, but the point is that some, possibly, maybe, some of these may be personalized and able to target. We have precision medicines in AML leukemia, acute myeloid leukemia, for the IDH inhibitors. Those are approved. FLT3 inhibitors, those are approved, but they're approved in myeloid leukemia, AML. So the question for us, as you're asking, what about the difficult to treat patient subtypes? Patients with MF, myelofibrosis, who have already had a JAK inhibitor now need a new therapy where there's nothing approved. What about clinical trials? What about combination therapies? What about accelerated or blast phase MPN? And this is where I think your question comes in. So yes to everything you said, yes to precision medicine. And can we use it to help diagnose our patients, prognosticate, and treat? And in the prognosticate, there's a new scoring system called the MIP70, David, which includes what you're asking about. It actually is the first time we're starting to include molecular mutations to give folks a good look at what their myelofibrosis looks like. Before, we used to use clinical factors and blasts, and now we're using it. So I would say it's helping us to diagnose, helping us to prognosticate, and possibly maybe, and we're working on the treatment angle, maybe helps us to guide personalized precision treatments for our patients.
Okay. It's interesting you touched on that tool, because that kind of leads into my next question. So many trial results take into account, I was seeing the MPN symptom assessment form as well as other scoring methods. And my doctor uses this tool, and I think it's very helpful to look at trends over time. If one's doctor is not using any symptom scoring tool, how might a patient discuss or perhaps suggest this with their physician during a consultation?
You're just asking all the right questions as we head into 2021, David. This is something that's very passionate to me. So my friend and colleague, Dr. Ruben Mesa, as you know, and you've interviewed him, is the pioneer, the founder of the symptom burden scoring. It went from a tool that was used in studies to now, as you know, it's a part of every major clinical trial in the field and part of the way we think about how these drugs work. So not only reducing the spleen, but reducing the symptom burden. What Ruben also was able to do, as you well know, is make the subjective objective. And what I mean by that is our patients with MPNs can have what appears to be a disparate group of symptoms to the untrained observer. Fatigue, bone pain, itching, night sweats, all of these things kind of seem random, except we now know that this is all part of the MPN. This is part of the disease process. The symptom burden scale, which is now simplified, essentially we call it the TSS-10, right? The total symptom score 10, may take a few seconds, a few minutes to fill out in the clinic. Now, I will say we're using this discussion for my expert opinion, and so not all of these things are FDA approved or on label or clinical practice. And it is true that the symptom burden scale has been validated and we use it in clinical trials. But I do encourage providers, it's all available online. You don't have to use the questionnaire because it's a clinic visit and you should do what you see fit, you as the MD and you as your patient. But I do think it helps. I myself strive to use it in the clinic visit where, again, these 10 questions, peripheral neuropathy, bone pain, some of these things don't always come up in a standard review system. So you're right, I do encourage it. I think it takes a lot of education on our part, uptake in the community, understanding that symptom burden is not just a part of the disease, but it could be the disease or the disease manifestation for our patients. And then understand that some of these therapies, JAK inhibitors and possibly these novel agents, can in fact reduce the symptom burden, therefore making patients actually feel better, not just doctor number stuff. So I guess that's my general take. I will say that it would help, and I have talked to some of my colleagues where these symptom burden questionnaires are part of their electronic medical record or EMR, David. So that obviously helps when there's an automatic electronic reminder, but most of us don't have access to that. So I think keeping up with the literature, watching interviews like this, going to ASH meetings, CME, I think the symptom burden score can catch on in the general community. And I think you make a good point that a full visit should encompass and incorporate us asking our patients and our patients telling us about symptoms.
Okay. And one of the reasons I mentioned that is, I hear in the community, some patients might discuss, well, my counts look good and we had a short visit for 10 minutes with my doctor and I've had problems with fatigue and bone pain and so on and so forth that were never addressed. And so that's kind of why I mentioned that.
Yeah, and let me follow up on that because that's so important. And we're all guilty of this too, because sometimes we as physicians don't ask, that's for sure. But then our patients and caregivers may either forget to ask, or as you said, these visits are so busy. And if overall everything's going well, it may not come up. And then a lot of folks think that fatigue has to do with normal aging. Or quote something else, because a lot of things can cause fatigue, thyroid, et cetera, and all these things need to be checked in the course of a workup. But make no mistake about it. Now that I've analyzed these symptom burden scales on and off clinical trials, fatigue is by far the most common symptom of our patients. You know that in all of your work and experience and interviews. So you're right. We don't talk about fatigue. It's unsatisfying to address. Maybe some of us, including me, we have access to a fatigue clinic, and that may benefit particular patients, but it is part of the MPN. It is the MPN for a lot of our patients, and not just myelofibrosis. Yes, even ET and PV in the quote earlier stages in the younger patients can have fatigue and MPN symptom burden that's way out of proportion to the blood counts or what the bone marrow says or anything. It just proves to us, again, Ruben Mesa and his group have shown this, that the MPNs are a very, very difficult to understand and appreciate disease, and they don't always follow the blood counts of the bone marrow. I'm really glad you brought that up. So a thorough visit, at least on the initial intake, and something in the subsequent should include all of these elements at some point.